My name is Doug Paauw, and I am a professor of medicine at the University of Washington School of Medicine, and I work in the Department of Medicine Division of General Internal Medicine. There's been a dramatic change in the last 25 years from the internist taking care of the patient from clinic to the hospital to a shift where patients have their outpatient doctors and they have people who take care of them on the inpatient side. And that has been a really dramatic shift over many years. And the impact on that is that when somebody has somebody they trust with their health, as happened many years ago, and then they got sick, that person was there for them in the hospital too. We've had to pivot to a system where individuals who are so specialized in the care of the sickest patients and give absolutely top-level care there have to also figure out a way for those patients who just meet them to trust them. And then more importantly, when they're ready to leave the hospital, have a good handoff to the doctors who are going to be taking care of them in the outpatient setting. So in my career, that's been the single biggest change. More recently, we've had a change to visits being much shorter and visits being done often online, including virtual visits or telehealth visits, which are really a wonderful thing for patients to be able to access their physician or healthcare professional in a quick way when they need it. And for some patients, it's very difficult to get into the clinic. The downside of telehealth visits is you get a limited data set. You can't examine the patient. There's a feel that you get when you're in a room with a patient, sick, not sick, that is a little harder on a telehealth visit. So the telehealth visits are a two-edged sword. The wonderful part is access, and for people that have to travel a long way, they can actually talk to their doctor and work through a plan together. The downside is we have to recognize it's not the same as being in the room when you need to examine a patient, or sometimes that connection that you only get when you are close to a person. There are a lot of positives with technology. The possibility of ambient AI being able to pick up the doctor-patient visit and then set up a very well done note that physicians can then just review, and it can cut down a lot of the charting time, which has been a real driver for burnout, the extra time documenting. When I first started my career, we did written notes. They were very short. Their goal was just to make sure that if somebody else took over the care of the patient, they'd know what your plan was. Now, notes are a lot more elaborate with a lot more information in them, so they can take a lot longer. AI can, and is being piloted, and some places accept this and are doing this, actually listen to the conversation, edit the conversation, and come up with a very nice note. So that is a real hope for AI in reducing burnout. One of the other things that I think has been a positive is as we've opened up the electronic record to our patients, they can really understand what's going on. They can pay attention to their health care, and they can make sure things don't fall through the cracks. They can ask really good questions, and I think in a lot of ways become even more engaged in their health care. So that's another positive that I've seen with some of the changes that we've had in recent years. More engaged patients who are more educated on what illnesses they have. Many times they will see, read about it, get more information, and be more engaged in their care. One challenge has always been that if you go on the internet and put in Google search or AI and say, who should a older patient see as a doctor, it will say a geriatrician. Unfortunately, we don't have enough geriatricians. There are very few of them in the United States, and estimates we have about 5% to meet the need of our older patients in the U.S. So internists have taken on the role of becoming geriatricians. Geriatrics fellowships are something that you do after an internal medicine residency to get even better at the care of our aging population. Internists see complex patients with multiple problems, and many of those are people that are older, because as we get older we start to accumulate diseases that can be a threat to our health. We have the opportunity to become expert in their care. Collaboration with behavioral health specialists is absolutely crucial for internists because many of our patients have mental health concerns, and especially since when people have depression, anxiety, it often manifests as physical symptoms, and so they come into an internist's office. And in addition, we have certainly seen increasing rates of depression, increasing rates of anxiety since the pandemic, and with lots of stresses in the world now, our patients need all that help. The real challenge has been we do not have enough behavioral health specialists to help us. The very best clinic models are models that have a behavioral health specialist in the internal medicine clinic available for consultation, even curbside consultations where you stop by their desk and ask them a few questions. That is optimal. That's what we want. Unfortunately, the vast majority of practices do not have that access, and access to behavioral health specialists can be limited in many areas, especially rural areas and some areas that have a undersupply of healthcare professionals to begin with. But the best system we can have is full integration with a behavioral health specialist. The biggest concern and threat to medicine and currently is the corporatization of medicine, the fact that most physicians are working for somebody else, and that somebody else isn't somebody who comes to your clinic and sees how you care for patients. That is an entity that sees it as a potential profit center, and so that a lot of the things that come down that frustrate physicians come from high up where they don't have a voice. And when people lose their voice, they lose everything. And I think that that's a big piece of burnout. And when I see individuals who work really hard but they have a voice, they don't burn out as much as individuals who don't feel they're heard. And I think this loops back to what we were talking about patients. When our patients feel heard, they feel health is possible. When they don't feel heard, they wonder about their health. And as physicians, our job is to listen to them and let them feel heard, but we also, as physicians, want to be heard as well.